So I'm forever grateful to Dr. Rhoton. I wasn't his fellow. I didn't spend the time in his place, but in a way, he was my shokunin. I follow him like many of you guys did, and we learned a lot. And I'm very grateful to him and Professor Kobayashi and all his pupils carrying this his wisdom and legacy. So I have no disclosures, and this is our beautiful campus. And I found out September is the National Brain Aneurysm Awareness Month. So I salute all the patients with the brain aneurysms or who suffered brain aneurysms. And Dr. Wen gave excellent lecture on anatomy. I'm not good anatomist, and many of these information is available, and everybody watching this webinar probably know more than I do. So I'm just going to jump, like Dr. Wen said, jump to the point and show you guys a few videos. Well, I think clipping in AComA, anterior cerebral artery aneurysms, proximal AComA or distal, to me is still gold standard because you permanently exclude the aneurysm from the circulation, and you have direct vision during the surgery. You have direct 100% control over the situation if you follow the principles of microsurgery set by our pioneers. You have the proximal distal control, and you can apply the clip, and you can confirm you completely obliterate the aneurysm by puncturing, cutting, or if you have angiography or other visualization techniques. How I approach to AComA aneurysm, A1 aneurysm, just if it is unruptured, not very complex, no mass effect, I like to do terminal craniotomy. But if it is ruptured, swollen brain, high hand has grade subarachnoid hemorrhage, I like to do modified OZ. And sometimes I combine with the, in some cases, anterior interhemispheric approach, but most of the time, terminal transsylvian. This is an example of A1 aneurysm case, young female, 48-year-old female with the left-sided decreased visual acuity and field defects, partially thrombosed, large aneurysm arising from the A1. And you can see the just part of it filling, and it's right at the distal part of the A1 before AComA. And I just, wide arachnoid dissection is the key in these aneurysms. Sylvian fissures should be open in most, maybe all of the AComA and this A1 aneurysms. It relaxes the brain, it separates the frontal lobe from the temporal lobe, and minimizes the retraction if you have to use retraction. And most of the time, retraction is just brief period of time. So we get the initial ICG to understand. And once I cannot do more, I put the clips here. I just jump it. I'm going to show you. I decompress the optic apparatus as much as I can. You see the Hübner artery here. And I am just mapping the live part of the aneurysm and staying away from it. So this thrombose part, and I'm opening the thrombose aneurysm, and I'm gonna using the sonopet, and it starts bleeding. That means temporary clipping wasn't perfect, and I put the pilot clip, and pilot clip allows me to get the more thrombus, but it's even in spite of pilot clip, now it starts bleeding from its base. So I'm replacing the pilot clip, taking the temporary clip, and I have good Doppler, proximal and distally. Now I can complete my thromboendarterectomy. You can see the avulse part and completing the dissection from the optic chiasm and optic apparatus. Now I have full anatomy, and I'm obtaining one more ICG green and completing the rest of the endarterectomy, thrombectomy. And once that's done, I can replace the clip more precisely and get the complete occlusion. So that's the way, and you don't want to be too ambitious with the neck clipping in some of the joint, and you see the Hübner, and last piece of the thrombus I took, and there is a fragile part of the neck you see it looks very purple, and this I don't want to leave that, and I place a small micro clip there. And she woke up fine, and her visual deficits start improving right away, and with the good angiography. So this is an example for A1 as proximal control, distal control, and in thrombosed giant aneurysm, you have to do thromboendarterectomy once you obtain the at least proximal control. And this is a 67-year-old Huntes grade 5 subarachnoid hemorrhage. To me, Huntes grade 5 subarachnoid hemorrhage almost like a patients with the GBMs. Nobody wants to do anything with them. I have a large series of grade 4s and the 5s, and I don't give up on these patients. And this is AComA aneurysm means all perforators. Projection, anterior projection, no perforators, superior projection, posterior projection, inferior projection. You have to watch the perforators. Three main group of the perforators: chiasmatic, hypothalamic, and subcallosal, and they supply important memory and important brain regions, especially the forniceal area and subcallosal area. And this is very tight brain, and ventriculostomy, yes. Large decompressive craniectomy, yes. And Sylvian fissure is 100% yes. You have to open Sylvian fissure in order to minimize the retraction and relax the brain. And in all ruptured AComA aneurysms, whenever you can, you have to get the lamina terminalis. And opening the lamina terminalis significantly relaxes brain in most of these cases. And the no retraction so far, and the principles: go to the proximal control, first proximal control ICA, second proximal control A1, and follow the A1. And I just opened the lamina terminalis, suction the clot from the anterior third ventricle, and then next is going to the other side. Other side A1, that will allow us, and as said, like almost 13 aneurysm you should see when you are doing the AComA aneurysm surgery. And A1s, A2s, Hübners, frontopolar arteries, and the perforators. So now I don't hesitate to take any gyrus rectus, ipsilateral gyrus rectus, that allows me to see the corner of the A1, A2 junction, as well as the ipsilateral A2. This aneurysm is anteriorly projecting, and one problem with anterior, they are okay to clip, relatively easier than the other projections, but they can be stuck to the optic apparatus. Early retraction can cause avulsion of the dome if it is attached to the optic apparatus, or sometimes even the planus sphenoidal tuberculum region. So this is anteriorly projecting. You see the ipsilateral A2, ipsilateral A1, Hübner, and you dissect Hübner well and detach, because with the traction you can avulse sometimes A2. I always get baseline ICG green, so I can compare. I'm putting the pilot clip, checking the Dopplers, checking the ICG green again, and this is pilot clip. I want to see the perforators, although they are away. I want to see the other A2, and everything looks okay, but I'm not happy because I'm not seeing the other side of it. I don't have the 360-degree exposure yet, so in order to do that, I'm puncturing. That's fine, it's not bleeding, but I have to mobilize, and sometimes bipolar modeling, sometimes cutting and bisecting the aneurysm helps you. I want to make sure the other side is okay, and the clip is completely crossing the neck. And I'm not happy, and since I'm not happy, I'm going to end up cutting this aneurysm. Once you have full control, you can do that, but if you are at the beginning, you may be afraid of doing this, but after you watching the many people, you gain experience, you can do this. And sometimes we fail, but failures don't let us to fear all the time, right? We come back. we are summarized, correct? Dr. Morcos is watching me. I have to be very careful what I say about him. So, and it's nice clipping. Yes, we clipped it, but how is he gonna do, right? It's a very long course, but eventually they do well. And my series of grade 4, 5s, MRSA score 0 to 2 in 1 year, 70%. It is very good results. So you can achieve it. Don't give up on grade 4s. Don't give up at grade 5s, okay? And solve grade 5s near 40%. So this is a grade 1, Hunt has 2 subarachnoid hemorrhage, suboptimally coiled at outside hospital. In this case, you see if AComA is very short and there is no enough distance between both A2s, and there's no way you can dissect and create a space for perpendicular clip application, you have to do fenestrated clip across the neck, crashing the aneurysm. And that's not possible in sometimes with the current technology we have. You know, shortest clip available is 3 millimeter. Sugita or Yaşargil clips, fenestrated straight or angle. So, and in this case, you can watch this video. Its segment was very short, and anytime I try to put 3 millimeter fenestrated clip, it is pinching this artery or pinching this ipsilateral or contralateral artery. So I learned this technique from my Nagoya days. I watched Professor Sugita. I was his last fellow, and he used to drill these clips, and I did it. And we have like 4 cases we had to drill the clip. It's good technique. Keep in your mind, keep in your surgical daily armamentarium. So this is another one. So coiling, right, is unruptured aneurysm. They coil it, and it ruptures several years after, 3 years after the coiling, it ruptures, and now it's grade 4 subarachnoid hemorrhage. And I mentioned you have to watch the 13 arteries, and this is the case. I don't want to take your time too much with these videos. Just try to be perfect with this clipping, okay? That's how coiling gain popularity, right? We were so afraid of doing the clipping, or we were just putting clipping and getting out. And that's not the way it should be. And we should follow the principle set by Professor Yaşargil. Check every single time, and until you get the perfect, then you are done. And these fenestrated clips in superiorly and posteriorly projecting aneurysms they're lifesavers, straight angle, and you can crash, and you see the Hübner artery here. And temporary clip, utilize, don't use too often. If necessary, only use if it's necessary, and short breath of time, and always allow reperfusion between short clipping times. Again, grade 4 subarachnoid hemorrhage, previously coiled, and at this is 3 months. In 1 year, she started running marathon again. This is sometimes aneurysms are like this. There is no projection. Everything is blown segment of the AComA. In these aneurysms, you have to be creative with multiple clip reconstruction strategies, and that's what we did here. And we got very good results. He's been aneurysm free almost 8 years now. Another one, be aware of the variations. AComA, A1 is very, these are the common locations for the variations. And this is the variations infraoptic course. You see, this is the ipsilateral optic nerve, contralateral optic nerve. A1 is coming under the optic nerve. And it is not technically difficult, but if you don't aware of these variations and if you follow them, you can get in trouble. Another one, grade 5, and whoever treated at that time, okay, let's do the coiling, and if she survives, we'll see. And he survives, good coiling, but recurrence at 1 year, you can see. And these aneurysms, if possible, try your best to avoid taking the coils out. Be prepared for bypass. And if you have a good neck, you can crash some coils. And most of the time, these coils, you can see they are extraluminal. Ipsilateral A2, ipsilateral A1. I am crashing again. In this superior and posterior projection aneurysms, I love this fenestrating clips, and you can really crash, and you always watch hypothalamic perforators in this location and free them, dissect them, and protect them. Good results, and he did well. He already made the good outcome. So this is a great for AComA aneurysm. Another example, and in this case, we use the crani-orbital approach. I'm going to the point, like Dr. Wen said, go to the point, dissect everything, do the lamina terminalis opening, and then find the aneurysm. You see the hypothalamic perforators, and this is the bolt dissector. I learned how to use this from Dr. Morkos, and going 360 degree if you can. If not, do your best exposure, get the neck, distal neck, proximal neck, put the clip, pilot clip, then see what you can do. If you are not happy and you have no flow, cut the aneurysm. You can cut it, no problem. And then that will allow you to see. So I'm putting another pilot clip on the top of that cut sac, and I'm replacing these and going for the perfect clipping, like my dear Japanese friends, colleagues do. They are perfectionists, artisan. They will do best, and that's how we should do. Real summarize. And good results, good outcome. What about this? This patient presented with seizures. Initially, they thought this is a meningioma. They do MRI, and they realize this is a partially thrombosed giant aneurysm. It's very complex aneurysm. In terms of complex anatomy, understanding the anatomy is complex, but you see here, actually, I go to the thing. Here, this is actually left side pericallosal aneurysm right after the AComA, and is very proximal, and is one afferent artery comes and other efferent artery goes. So there is no branching point here. But I love this partially, mostly thrombosed aneurysms because it allows you to debulk significantly. So you can really get chance to look around and then reconstruct. Our strategy, first reconstruction. I always go for reconstruction, but I'm prepared for A3 bypass if possible. If not, I prepare STA, and arm is also prepped and draped just in case if I need another graft. If A3, I cannot get it. And now I'm opening the aneurysm, and entire video, whole length of video, you can watch it. You go, and the exposure requires, in my opinion, required transsylvian and interhemispheric exposure. So we did a large craniotomy, and brain was quite swollen. We had to put the ventricle. So we start seeing the anatomy now. Proximal pericallosal, neck, and distal pericallosal. Once you get this anatomy, you can continue to get, you can continue debulking, thromboendarterectomy, or if you sense that you're gonna take less than 10 minutes, you can just put the temporary clips under motor evoked potential monitoring. And once you get that, try not to be very ambitious with the neck occlusion, because these thick wall aneurysm, you can occlude the orifice of the arteries. So just initially do your best, get the temporary clips out, inspect, and then you can perfect your thing, and even you can suture like we did here after removing some of the clips. So, and he did very well. As you can see, we left the base here, and that's all you need to. And he's been doing very well last 4 years. And this is a very complex case, 10-year-old with headaches, partially thrombosed pericallosal aneurysm from the left, and you see is fusiform, partially thrombosed, very ugly shape, and this is proximal pericallosal and very small pericallosal. And there's no way you can deal with this endovascular means. So you have to do some kind of surgery. And how? A3 bypass, then trapping, or just simple trapping. And or if A3 is not enough and you see this branch is quite small and there's a big space, if you cannot free and bring them together, you can do jump graft from ipsilateral STA to A3, then trap. But first, you look at all the collaterals. There's no good posterior pericallosal collaterals. So even though it looks that way, I always do ICG green, put the clip. If there's no simultaneous filling, simple trapping is not going to work. You're going to give this 10-year-old distal ACA infarct. And we open the sylvian fissure, we open the proximal. First, I am looking for the both arteries, and there is no way you can bring this. I dissected, eventually decide A3 is not possible. And I put the temporary clip, ICG green. See, it's not filling simultaneously, so that means you cannot simply trap this. Opening the sylvian fissure, going for the proximal control, and now the plastic surgery team start harvesting the radial artery, and I already dissected the STA branches and radial artery here, and soon we realize there's a big hole in the radial artery, and we repair that. And radial artery we measure, we did the preoperative MR angiogram of the arm, everything, and still it was short, turned out to be short, although initially we measured 18 centimeter we need. And this is very narrow space. Doing the proximal bypass distal bypass first, A3 to radial artery bypass, nice backfilling. Then, since it's short, I have to go for the frontal branch, and frontal branch, there's a big size mismatch. I'm using the tapering technique. This is we published before. So if you have a tape, you cut obliquely and bring together. And bring that. It's small, still mismatch, but there's no other option other than using saphenous vein, and that's we already done the distal bypass. Taking nice filling. And look at this, all filling nicely. A3, postoperative day 3, postoperative 2 months, radial artery counts A3, and he's back to school. So I think I'm taking too much time, but also I told you guys, don't give up anytime in any aneurysm surgery. Huntes grade 3 subarachnoid hemorrhage, distal ACA. What I planned that this is left side pericallosal, crossing the right side, but just exposing the interhemispheric fissure, not just true bifrontal craniotomy. And we prepare for that. Patient had the ventriculostomy that night in the morning, electively, and I was washing my hands. Chief resident called me immediately, coming out, said that ICPs is 100, frank blood is coming from the external drain, her blood pressure is low, bradycardic, and she's dying basically. So suddenly I turned this small interhemispheric approach to a large bifrontal craniotomy, and his dura is so stuck. I did one side, you see the brain herniating from the right frontal side, and then we gave adenosine to stop the bleeding. It's constantly, she's bleeding from the ventriculostomy. And I went for the right side, although initially I planned going to left interhemispheric. I am doing the temporal frontal polectomy, lobectomy. And once I get done, brain is controlled to ICPs, I go to the lateral ventricle, okay? Go to the lateral ventricle first, that decompress, that I know there's still bleeding from here. And every time I try to suction, and the blood is coming. But at least we stabilized the ICPs. Then we went for the proximal control. We found the proximal control, and we didn't give up. And finally clipped the aneurysm, and this aneurysm was constantly bleeding during the exposure. But once you get the proximal control, everybody relaxed, patient is stable. We gave her a pentobarb, and now there's no active bleeding. until I cause the bleeding. And I'm moving with my temporary clip from very proximal to distal, so diminishing the ischemic area. And again, I got the re-rupture again while I'm dissecting, but I have full control. This is not a problem. And I coagulate the dome, separate it, and now I can get the aneurysm. Neck is done, neck is exposed. You can get the very good clipping, remove the temporary clips, and this is the final appearance. And everybody want to give up on her. This is the cranioplasty after a few weeks. So, and believe or not, 6 months MRSA score 2, 15 months MRSA score is 0, and she's living normal. She was gonna die if she was in the operating room. If she didn't rupture, if she ruptured on the way to operating room, she will have died. But we didn't give up. So never give up on the brain aneurysms, okay? And go to the lab. Always go to the lab. Anatomy is everything. And wide dissection. Don't get stuck with the keyhole surgery, pinhole surgery. I go to the clip the aneurysm from the eye. Do the best for you, for that patient, okay? Wide arachnoid dissection, proximal, distal control, 360 if you can expose, then perfect clipping. Don't waste your time with the terminology and those coining the terms, okay? Anatomy is everything, and this meeting is all about anatomy. Read, listen, watch, dissect. I hear, I forget. I see, I remember. I do, I understand. Thank you for your time. I always exit my time, and sorry, I apologize.